welcome to the Transitions Case Management Society of America Leadership Panel. I'd like to introduce you to some of our leadership panelists, and first I'll go ahead and introduce John Heraty, who is our incoming CMSA President of Chicago. And so thank you for joining us, John.
Thank you for having me.
And then I'm going to go ahead and introduce our guest, Colleen Morley, who is our Illinois and Chicago president of CMSA, and she is our president-elect for the nation. Thank you for joining us today.
Thank you.
And then we have Melissa Popp, who is our executive director of our hospice at Transitions. Thank you for joining us, Melissa.
Thank you.
So today we're going to talk about case management and how case management works in the Illinois level, and then how it works within our hospice. So I'm going to be moderating the session. So what is your new role, Colleen, and what will you be focused on?
Well, my new role, I will be transitioning to being past president for CMSA Chicago, and I'm handing over the reins to John, who's going to be our first social worker who's president of CMSA Chicago, so congratulations.
Congratulations, John.
In the meantime, I'm also taking over office as president-elect of the CMSA National Organization, and that's an incredible honor. I was so overwhelmed to be elected to that position.
Congratulations.
Thank you. To be able to represent case managers across the continuum of care and across the nation as well.
How long have you been involved in the organization?
Oh my goodness, it seems like a lifetime, because it has. It's truly, when you love something so much as I love CMSA, you don't really count the years or the hours, you just live in the experience. So I would say I've been a member of CMSA for at least 10 years. Probably more, but I've lost track because it's part of my life.
Sure.
What inspired you, excuse me, to run for CMSA National President-elect? And how did you decide to go for this and go through with it?
I would say what inspired me to run it is just this really passionate desire that I have to be the advocate for the advocates.
Mm-hmm.
Case management is one of the best kept secrets in all of healthcare. Still, we've been in existence for over 30 years. But people still don't understand what a case manager does, or who a case manager can be, or how a case manager can help either the interdisciplinary care team, the patient, whatever's going on. And case managers live in a whole bunch of different areas. They're in the hospitals, they're in the managed care organizations, they're in the communities. They're everywhere that you've got interaction in healthcare, but nobody knows about it.
So that begs the question, and this is for both of you, what is case management and who is part of the team?
Well, I'll start by giving you the textbook definition. The textbook definition is that case management is a collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates options and services that are required for our clients to help them meet their health and human service needs. That's your textbook definition.
Mm-hmm.
Anything else? From your perspective, John?
And who's part of the team?
Yes.
I like using metaphors. Colleen gave a perfect textbook definition, but I think of very excellent adult daughters, adult sons who are managing their children, managing their parents, and they're trying to get them through a life issue. A case manager has the professional skills, whether it be a nurse or a social worker, to help a person navigate through oftentimes a very complicated health system, whether they're in the community or in a facility.
Wonderful. Now, what resources do do you need to have available for the case management team that you work with to do their job?
Well, first and foremost, you need your patient. Second, you need the interdisciplinary team that surrounds that patient. So you're talking
Mm-hmm.
about your physicians, nurses, social workers, case managers of whatever discipline, services, durable medical equipment, hospice, home health care, skilled nursing facility. You need all the things that make it easy to transition a patient from where I work in acute care,
Mhm.
you know, from the hospital back into where the patient needs to go. Whether the patient needs to go to rehab for a little while and then go back home, how are they gonna be successful at home? We're not just going to discharge them from the hospital, wave them off and say, congratulations and good luck to you.
Mhm.
We're going to make sure that they have everything that they need in order to be successful at home.
So that means the community,
Yes.
you know, payer source, extra, you know, you work with them through
Absolutely.
that, you know, and that can be a big part, right?
And that's one of the reasons that case managers are such a vital piece of the healthcare team, is because we do help navigate through this incredibly complex healthcare experience. You've got the hospital, you've got the physicians and the other services, and you've got the payer, and find me somebody who's actually sat down and read their entire insurance policy.
Right.
I mean, I can tell you a story from when I was a younger nurse, where my 12-year-old son ended up in the emergency room from eating, you know, too much cheese, and ended up getting a horrible case of constipation. And we were in the emergency room overnight, and then I got a bill for over $4,000 because I hadn't read the insurance policy, realizing that it didn't cover emergency room care.
Interesting. So
Wow.
it doesn't seem like every patient who goes into the hospital may be aware that there is this case management piece or the
Exactly.
availability. Now, does every hospital system usually have this? And if they don't have it available to them, how do we, you know, help them understand that?
Every hospital system has a case management department. And
Mhm.
it's made up of case management nurses, social workers, discharge planners, administrative services, and we're there to help not only communicate with the insurance company, but we're also there to help with the discharge planning and the coordination of care and benefits after the patient leaves the hospital.
Very good. So, Colleen, I think you have some questions for our
I do.
executive director of our hospice.
Melissa, hi. So how does case management coordinate in with hospice and palliative care?
So specifically with hospice, our case managers are heavily involved in the patient's care, even on a day-to-day basis, and they're the ones going out to see their patients. And they're sort of the glue to the whole piece, you know, as you were mentioning, and, you know, they're kind of the messenger to all the other members of the interdisciplinary team in overseeing the total care of hospice and
So
palliative.
they are the care coordinating entity
Yes.
there.
Yes.
That's excellent. And so when we're talking about hospice and palliative care, that's two different areas. And we know that hospice is for end-of-life care. Can you talk a little bit more about palliative care, and how can palliative care help my chronic condition management patients? From a hospital perspective, we're really concerned about readmissions, and a lot of the patients that we see coming back in have these chronic conditions like congestive heart failure and COPD, or chronic obstructive pulmonary disease. So we really need to try to manage them outside rather than having them come into the hospital so frequently.
Sure, so our palliative care team is, you know, out in the field seeing the patients, a lot of home patients, and the goal, of course, is to keep them at home and not send them into the hospital. In the event that they are in the hospital, you know, getting them out as quickly as possible and figuring out a way to ensure that they're not sent back to the hospital. So education, we can manage patients in their home with IV fluids if they need it, you know, IV Lasix, whatever it may be, based on the disease process, to prevent further hospitalizations.
And that plan of care is overseen by a palliative care physician as well, correct?
Yes, and nurse practitioner and social
Beautiful.
worker, yes.
Wonderful. So we've talked a little bit about how they help prevent the rehospitalizations. And symptom management is very, very important with our chronic condition management patients. How does the palliative care physician and nurse practitioner work on creating a plan with the patient?
So we have disease-specific, you know, treatment plans. Of course, every patient is unique, so care plan is developed based on the patient. So the nurse practitioners work heavily with the palliative care physicians and other specialists to ensure that their symptoms are best managed in the home, you know, specifically. Dr. Kapur, you mentioned those care kits that we're able to provide based
Right.
on disease-specific conditions.
We have jetpacks in our palliative care program that we try to predict what might come about, and we create the plan of care based on the patient's goals in palliative care, as Melissa mentioned. And the idea is to delineate before a acute crisis happens what they would want to happen in that situation. And oftentimes if the prognosis is poor, those acute maneuvers may not work. So we educate them along the way, practice polypharmacy, manage their symptoms, and of course address the psychosocial, psychological side of what they're going through as well.
Excellent. So when we're talking about, we talked a little bit about the resources that people need. Social determinants of health are 80% of the issues when it comes to people coming back into the hospital or having readmissions or even being able to manage themselves correctly. So 80% of what we as case managers do is connecting people with resources, with services out in the community. John wrote a great story for our books. CMSA Chicago puts out a new edition of our Tales from the Front book every year. And John wrote a phenomenal story last year about a patient that he worked with as a telephonic licensed clinical social worker, connecting this lady with services. Do you remember the story that we were talking about? Where you connected her with a plumber to fix the leak?
Oh, right, exactly.
Yeah. Can you tell a little bit more about your experience, even in doing that kind of stuff?
Right, yeah, and it's interesting because, yeah, so just doing a telephonic piece of it, she lived in a very rural part, and it just, sometimes things get complicated for people environmentally in their home, and they're trying to figure out who are trustworthy contractors, how they're gonna get the money to fix it, and just getting on the phone, talking to local people, and just trying to harness as many community action people as possible, because there's all sorts of aging offices and disability offices where they have money set aside for housing assistance. And I'll just say this finally, to me, one of the most important things of case management is to wrap the case management in a clinical blanket, because it's not just having a rote conversation. I mean, hospice particularly, but even any type of case management is understanding that there's a human being there and talking in a certain way, yeah.
Right. Yeah. And just being sensitive, I think, to not only the situation the patient is going through with compassion, but also like what they've been through, in their life. Everybody's a unique individual, and that's one of our commandments here at Transitions, actually, is that we treat them as, a unique individual with a unique plan of care. We're not cookie cutter.
Mm-hmm. Exactly. I mean, my mantra is patient-centered care, and I feel that that's exactly what case management does, is really takes a look at, the patient, their situation, includes their family, and really wraps those services around, like John said, to make sure that all the gaps are closed for those patients.
And I think one of the things that's unique about Transitions is the fact that sometimes the patient is fairly stable. They may have a 6-month or less prognosis. However, a lot of the support we're providing is strictly for the family. And, sometimes they're the ones that need the support most.
Exactly.
Very good point. And oftentimes, we'll see in these cases that addressing the psychosocial need allows them the family as well as the patient to come to an area of acceptance, and so that they can get the right type of comfort-focused care at the right time. Otherwise, we're pursuing chemo when, there is another option there.
Well, and that also, going back to the readmissions discussion that we had briefly, a lot of times the patients are not the ones that are saying, take me back to the hospital. It's
right.
The families who may be getting very anxious with, mom or dad going, doing that slow downward trajectory, and they're like, quick, I'm not ready for this, But in moving with the patients and bringing their families into it and creating that safety net for them, it gives them a little bit more reassurance and a lot less anxiety to just knee-jerk throw mom in the emergency room because I just can't handle this.
Yes, absolutely.
Very good point. The voice of the family is very important. There is that saying, a psychiatrist once taught me, is that, don't treat the family through the patient. However, they do have a large portion of it, especially if they're the power of attorney for healthcare, to know what the wishes are and act on that patient's behalf. So thank you for those points. So thank you very much for the information on case management as it relates to nursing.
And social work.
And social work. going to be talking about social work as it relates to case management. And I'd like to introduce, again, John Heraty, who is our CMSA Chicago incoming president. Welcome, John.
Thank you, Doctor.
And then also, this is Colleen Morley, who is our CMSA Chicago president, and she is also the CMSA national president-elect. So congratulations on that. Thank you. And we also have Stephanie Tintner, who is our director of ancillary services here at Transitions Hospice and Palliative Care. Thanks for joining us. So today we're going to go ahead and talk about how do social workers engage in case management.
Great. I'll just tell you a little bit about my background. I was an accounting first, and I went into social work, which is a real, and they say you use your history to bring into your current position. So I started doing crisis counseling at a hospital. So that's where you can see case managers, and then doing community-based case management, and now doing managed care. So it just goes to show you, case managers, it's really infinite what they can be. So it could be in a school system, it could be behavioral health, psychiatric case management, it could be substance abuse, facility, hospital, rehab, could be in a dialysis center. Just anybody who needs care managed is in need of a case manager.
Great, thank you. So social workers are considered case managers, and so there is an infinite amount of settings, and they have sometimes divide duties, exactly. What do social work case managers do in different settings? What can they and maybe what they cannot do related to case management?
Right, okay. So I'm a managed care social worker, and one of the things that I particularly like about this role is you talked, it's all telephonic, but in some of my other positions, I didn't collaborate nearly as much as with nurses. So being able to read the documentation, because the nurses many times are like the Marines, they're the first ones in. So I'm able to kind of piggyback off the great work that the nurses do, and then they say, we'll have our social work call you. So we have our own particular assessment that we use that really focuses on the psychosocial needs of the person. So that's like a managed care, but again, you could have case managers in facilities, hospitals, who are helping them transition from the hospital to home. But you also have, case management is also really important in the community, and they might be in an assisted living or most likely in their home, because sometimes we think about, let's just get the person home, let's get them home health care, and then say our prayers or whatever, and it's like, many times these folks need assistance, and case management is really connecting with them, maybe having home health care, looking at all their environment, the person in the environment. Do they have stairs? What type of barriers do they have? And trying to connect them with resources to make them thrive in a home.
So what capacity of counseling goes along with, for example, transitioning somebody from the hospital to their home? You know, might there be something that comes up, and then how long do you follow the patient?
Right. So now I am not a hospital case manager. That is Colleen. I do talk to a lot of hospital case managers, and I'll say this, is that as a managed care social worker, the thing I kind of am proud about is no matter how good of a hospital case manager does, they're only case managing that person for a day, a week, whatever their length of stay is.
For the episode, okay, got it.
However great a home health care worker is, they're only in for the event. And a home health care event is a max of 60 days unless the doctor writes an order. But there's other types of case managers who are more long-term case managers.
Okay.
A person could have somebody with the Office on Aging who is that person's dedicated case manager for an extended period of time.
I see.
They may have coordinated help in the home and help them continue to navigate their long-term care needs in the home. As a managed care social worker, it's part of their insurance benefit, so I'm able to talk to them at their bedside in the hospital, and then when they get home to see how things are going.
Okay.
Did the home health care nurse come by? Yeah, her name is Susie. Do you want me to talk to Susie? Oh, you need a hospital bed. Okay. We'll get you a hospital bed, and we'll move that progress along.
So do all managed care organizations have a case management, a social worker, or do some not have it?
So, at least the organization I'm with, some of the big healthcare companies,
I see.
they don't have a choice. Case management we get funded through the government.
Okay.
Right? So we're like a Medicare replacement plan, and a lot of people know it as a Medicare Advantage.
Okay.
So everybody has a case manager. But see, what happens is there's all different logarithms and analytics where it triggers a case manager based upon medical need. But let's say a person slips through the cracks.
Right.
The computer didn't say so-and-so our member needed a case manager. One of the things we tell our members is that please just let member services know that you're interested in the case manager.
Right.
Because typically it's a little bit of a hierarchy. It's the nurse case managers and then the social workers. Nurses in first, and then the nurse is the one that decides, do they need a social worker?
I see.
They might have transportation or financial assistance. There might be abuse going on. Could be 100 different things.
It's an excellent service from what you're describing here. And Colleen, do you have anything to add to what John has highlighted?
Well, I've used to work in managed care as well, and I know that it is part of the benefit for anybody who has any type of an insurance. And if you haven't been outreached by a case manager, whether it's a nurse, a social worker, an LCPC, there's many different levels of case managers in the managed care organizations, then it's one of your benefits. And please, feel free to pick up the phone, like John said, call that number on the back of the card and say, hi, I'm Joe Smith, and I think I need a case manager. And they will get you connected with your case manager, and they'll do an assessment and figure out what they can do to help you out and what benefits are available to help service your needs.
That's wonderful. I find that, we come across a lot of home health companies, maybe that, the patient who is on our palliative care program has a home health company involved, and they don't know that there is a social worker that's available to them within both programs. So it's important for the patients to know that.
Exactly, and it happens very frequently in the hospitals too, when the social workers and the nurse case managers go to the bedside. The patient is like, well, no, I don't need, this, and then we do an assessment with them, and they're like, wow, I guess I do.
This is great, yes.
So, having that extra, helping hand to help them see what they may or may not have at home and what they may or may not need is very helpful. It's an outside vision.
It's a very important part of patient-centric care. So Colleen and John, I know that you have some questions for Stephanie, who is our Director of Ancillary Services here at Transitions.
So Stephanie, exactly what does a hospice or palliative care social worker do?
Yeah, absolutely. So the short answer is a lot, but more specifically, a couple of primary duties. One is resources, so very similar to the case management role that you guys have explained to us already, is working with our patients and families. Oftentimes we're caring for someone who's in their home and they have loved ones who are their primary caregivers, and they're not realizing how much work it is to take care of someone 24 hours a day.
Absolutely.
And so what we're doing is we're coming in as a social worker, we're assessing the situation, we're assessing the needs of both the patient and their support system, and then finding resources that match. So that can be anything from caregiver support, it can be homemaking services, someone that needs extra help around the house, they need someone to help them get groceries, any resources that they may need. The social workers really specialize in finding those. The other part that we find ourselves doing a lot is that emotional support. So obviously you can imagine whether it's palliative care or hospice, we're dealing with a lot of complicated emotions that come up, especially with the acute, the chronic, serious illnesses. And so having a social worker who's able to not only support the patient, but also their support system and help them through this journey, whatever that may be, dependent on their illness, is really a key component to the hospice and palliative care system. And then lastly, I think we do a lot of advanced care planning. So oftentimes we see when people are coming from a hospital setting or from their own physicians, they're not having those conversations of, what do you want for your future? What do you want in an emergency situation? And so our social workers are typically the ones who are helping guide people through that process. What needs to be in place to make sure your wishes are met? What are your goals of care? Make sure that we have what we're doing aligned with what their wishes are as well. So it definitely encompasses a lot.
Okay, so how do you determine a patient's needs and then develop that plan of care?
Yeah, so initially we do a biopsychosocial spiritual assessment where we really assess all of the patient's needs, their support system needs, but truly it's an ongoing process. When we're looking at assessing needs for a patient, it's not a one-time assessment because as people are going through the disease process, they're progressing through whatever it is that they're going through, needs are changing. So our social workers really are in there and they're assessing needs every time that they're seeing or they're talking to a patient or family member, also utilizing the interdisciplinary teams. So when we meet together as a group and we discuss what's going on with patients, with their support systems, that allows the social worker the opportunity to get other pieces of the puzzle that maybe we haven't been privy to, and then they can come together to assess the plan of care, assess the goals, and make sure that what we're doing is still working for the patient and their support system.
So is there a specified time frame, like we're going to assess at this time, at this time, at this time, or is it more of an ongoing kind of?
Yeah, so in hospice, we do have to do an initial comprehensive assessment within 5 days of someone coming on services.
Mm-hmm.
So that's really great because it allows us to get in there very quickly and address any needs that are very critical so that we can get resources in place, we can get support in place, we can make sure that people have what they need immediately. But other than that, it is very fluid moving and it's dependent. We do depend a lot on our nurse case managers. They are in the homes and the facilities with our patients and their support systems more often than what the social workers are. So they will often come to us with concerns or questions about what may be happening, what some needs may be. So we really work together as a team to make sure that we're continuing to assess the needs.
Excellent. You have any questions?
I find it fascinating, and one of the things that is interesting is that sometimes the patient might tell one discipline something and not another discipline.
Yes.
So true.
I often tell people when we're coming into a home, whatever that setting may be, and we're with a patient or family, you're leaving with a piece of that puzzle. And each person leaves with a different piece of that puzzle. So when we come together as a team, that's when we're really coming together and we're putting the pieces together so that we can provide the most comprehensive care and support to that patient and family. Because absolutely, they're telling the CNA one thing, they're telling the social worker another, a nurse may see something that a family member has said or is experiencing that no one else saw. So it's really important that that interdisciplinary team's in place.
And sometimes that is the key to the puzzle. We had a case recently where I got a piece of the puzzle, and then when you put your piece with my piece, it was like,
yes.
The patient family thought that they were sinning by not, I think it was, I'm not exactly sure what happened.
Yeah, there was some spiritual turmoil which was
Yes.
preventing the person from feeling like hospice was really the appropriate level of care for them.
Right.
And so they had said something to Dr. Kapur about why they were hesitant on hospice services, and then when I spoke with them, I got a completely different picture of what was happening.
Right.
And together, when we put our pieces together, we're like, aha, okay, now we know what's going on, and now we can help support them in a way that's going to provide the best care and service.
And that is truly the unseen benefit of having this large interdisciplinary team
Yes.
that works within their scope of practice. So you've got your physicians doing physician things, you've got your nurses doing your nurses things, social workers, therapists, pharmacy, all these other disciplines that come together to care for this patient. And because there's so many different moving parts, we see different sections of it. And coming
Absolutely.
together as a group and then having care conferences and having discussions about how are we going to develop care plans for this patient, you get all that information all together rather than Dr. Kapur going, well, this is what I saw, this is what the care plan is going to be.
Mhm.
Or
Right.
the nurse seeing, okay, this is what I saw, this is what the care plan is going to be. It's a team effort.
It truly is, and there's a core team, right, for hospice, and then also we do these interdisciplinary teams for that purpose within both of our programs.
And I think that's really the unique feature of palliative care and hospice, is because when you think of traditional medicine, you're not walking into a doctor's office and getting a social worker and a chaplain and a nurse and a
wouldn't that be
CNA,
nice?
right? It would be, and hopefully that's the future of medicine, honestly. But you're not getting that. So you're getting someone who's focused on disease and they're focused on curative treatments. But then when you look at someone who needs palliative care or hospice services, you're looking at someone who needs that holistic approach to medicine. You're looking at the person who is discharged, their oncologist said there's not much we could do, or here's your treatment plan, but that person doesn't have transportation. So how are they gonna get to their treatments? So that's where you have a social worker and you have this team who comes in and can really look at the full picture, not just focus on the disease, and really help that person through the journey.
Beautifully said, everybody. Thank you so much for joining us. And now we're going to be talking about case management as it relates to mentorship, education, and chronic care management. And I'd like to introduce John Heraty, who is our CMSA Chicago President-elect. Welcome.
Thank you, Doctor.
Okay, and John is a wonderful social worker in managed care. And then we have Colleen Morley, who is also here, who is our CMSA Chicago President and USA President-elect. So I'm surrounded by a lot of presidents here today, so this is quite exciting. Congratulations.
Thank you.
And then we have Trish Benson, who is our former Chief Operating Officer of Transitions Home Medical Group, which contains our palliative care branch, and now she is the President of Transitions Home Medical Group. So as you see, I'm surrounded by presidents. Welcome, Trish.
Thank you.
So we're going to start with interviewing Colleen on how basically, chronic care management relates to case management in her field. So go ahead, Colleen.
Oh, wow. What can I
It's a
tell you
broad
about chronic
topic.
care management? So I've been working, we've been working with readmissions since 2009. It became a really hot topic in 2009, which coincided with my return to the acute care side of case management. So readmissions, we're looking at chronic condition management, we're looking at our congestive heart failure patients, our chronic obstructive pulmonary disease or COPD patients, our end-stage renal patients, so conditions that will continue on with the patient from the time of diagnosis on to when they leave this world. And we're looking at how we can reduce the readmissions to the hospital by making sure that they have everything that they need to be able to be successful when they go home. And that, we're still looking for the secret sauce. We're still looking for what's the magic ingredient here.
Mhm.
And there's a lot of work that's been done. If you Google readmissions since 2009 under scholarly articles, there are over 12,000 different articles and projects that have been happening since 2009, just trying to address how are we going to reduce readmissions. And there's lots and lots of different programs that are out there. There's transitions programs, there's Project Red, there's the transitional care model, there's lots of formal big projects out there. There's also some studies that have shown that a lot of facilities look at these different models that are out there and they pick a piece from this and a piece from that, whatever is going to fit their population,
Mhm.
and they create their own little hybrid model. So they have their own hospital-specific models that work with this. Whether it's putting 30-day transitional programs in place, whether
Mhm.
it's doing extra education, we're still trying to figure out what the secret sauce is as to how are we going to reduce readmissions.
Mhm.
And that's really the best management that we can come up with right now for our chronic care patients, because we've got patients who come in at a stage 1 of congestive heart failure and they go all the way through stage 4, stage 5s, if they're stage 5 now, depends on which one you're looking at.
Mhm.
How are we educating our patients on what to expect, and how are they prepared, and do they feel confident enough to manage their care at home? And the reason that patients are coming into the hospital, from a lot of the research that we're seeing, is that these patients are not confident to take care of themselves at home. They don't know what to do.
Mhm.
They get short of breath. don't know if you're, I have asthma. When I get short of breath, I get a little panicky too. And my first thing is like, hey, I need some help. If you're getting short of breath like that and you end up in the emergency room because you want somebody to fix this problem, where unfortunately these are chronic conditions, so this problem is not going away. What we need to do is come up with management and including that patient into how are they going to manage it and educating them on how to take care of themselves.
I think that's a very good point you bring up, is the autonomy of the patient. Not only the autonomy, but the part that they play within their own management and empowering that. How do you see that the social work and the nursing piece fit in from a case management perspective in chronic care to make that happen? We have our way we do it, but how do you accomplish that?
I think from an acute care perspective, really understanding where the patient is and if the patient can, health literacy. It's my newest soapbox, it's one very, very dear to my heart right now. Really recognizing that we have a tendency as healthcare providers to speak in a language called medicalese, that the patient does not understand, it does not have a translation, there's no Google Translate for medicalese. That we have a tendency to send people home with 4 inches of discharge instructions and medication monograms and all their instruction. Oh, here's a 4-inch thick thing about how to take care of your disease management, and you've got 4 or 5 different diseases, so they give you the monographs on every one of the diseases and the monographs on every one of the 15 different medications you're going home with. So it just keeps piling up and piling up and piling up, and it's written in a way that lay people can't read it. So they go home and they've got all this information and they're overwhelmed. And what do? They take it and they put it in a drawer.
Right.
Or they take it and they put it under a plant to absorb the water, like the one gentleman I talked to did. So we're not doing them a service by over inundating them with too much we're giving too much information.
At once.
It's totally a TMI, and it's totally in a way that they're not able to digest it. Small bite-sized chunks in a way that they can understand it. And I think John will agree with me when he's doing his telephonic outreaches. He's not talking to them in medicalese.
Right.
Right. So, yeah, and I'm fascinated by all that because it's a very complex.
You're very interesting.
And what was going through my mind when I was hearing Colleen talk about all these things, all the scholarly articles, is that number one, it costs a lot of money to help people. Number two, you have to have a stakeholder, okay? Like your parents, you're like, these are my parents, I gotta take care of them. Who are the stakeholders for people that they don't have a lot of family?
Sure.
And I'll just say this, as a managed care social worker, this is just from the managed care perspective, health insurance companies have a stake, they have skin in the game, okay? Because these are our members. If they go to the hospital, we pay for it, okay? So that's why they call it managed care. So what we want to do, and the game is changing so rapidly. Like at CVS, what you're going to wind up having is life preservers all over to say health hubs, right? So like at CVS, instead of having, they're going to cut down on the Snickers. I can't speak for CVS, but you'll probably wind up seeing less Snickers and Milky Ways and more health bars, dialysis, advanced practitioners, social workers. So there is a lifeline where these folks, instead of going into a scary emergency room, they can pop, down the block and go to a CVS. Or I could call them, or a nurse could call them, because we're advancing virtual care, right?
Right.
And virtual care, you can literally talk to somebody for a minute and do a course correction. One of the things we do is that it's a psychosocial assessment, but its basic things is, are you lonely? What do you do for enjoyment? Colleen told me that her hobbies saved her dad's life. We can't forget about all the different things that make up a person. And when you start asking them, are you lonely? or what do you do for enjoyment, you start building more and more of a connection, which reduces readmissions to hospitals.
That's amazing. You bring up some very good points as well. I think that, the way that you do it is very comprehensive, and how often are you outreaching to the patients, or does it really depend on what program it is?
It really depends on what program it is. And programs that I've put together at several different area hospitals here in Chicago, we've got a nurse and a social worker working together, reaching out to the patient. They would reach out to the patient within the first 48 hours of discharge, go back over the discharge instructions, make sure that they understood everything. Did you get your medications? Can you not get your medications? We can get them delivered to your house, a lot of gap finding. And then we would set up weekly phone calls, and the patient always had the opportunity to call directly. We had a direct dial number for that nurse and social worker team.
Perfect.
So the patient could always call back and find, hey,
Right.
I'm having some issues with this, or I don't understand that. But each time that they were calling, they were doing gap finding. Okay, your follow-up appointment is on Tuesday, I'm gonna call you on Wednesday. And they call on Wednesday, oh, you didn't make your appointment on Tuesday, well, what happened? Oh, you didn't have transportation tweaked out at the last minute. Let's go ahead and remake that appointment, and you know what, I'm gonna set up transportation for you because it doesn't sound like you've got, somebody that can take you whenever you need to go.
So that engagement with the patient allows for best care and obviously reduction of readmission. Now, in our world, in our palliative care, chronic care management world, we echo some of the way that is done. And so I'm going to have you go ahead and interview us.
Great. All right, so we're talking about chronic care management. How does transitions engage with chronic care management? I know we talked a little bit earlier about palliative care, so tell me a little bit more.
Right, a very large percentage of our palliative care patients are enrolled in the CCM. So the chronic care management piece of that is performed by coordinators on our team. And they're making those phone calls, they're touching base with the patients, and they're finding out, they're looking at their plan of care and their medication refills need to be made. And that really does help staying in connection. It helps avoid some of the rehospitalizations. These phone calls are made monthly, and they do spend the 20 minutes at a time with the patient, just going over some of those details. And then, Doctor, you can elaborate a little bit on that as well.
Right, so, and there's definitely that transitional care component of when they come out of the hospital, where we're going to capture, the needs of the patient. And as Trish mentioned, then there's the chronic, care management piece that, envelopes the patient. And as these patients that have serious illness become more acute in their illness, they become a kind of acute palliative care patient, which we, talk about these patients monthly in each of our areas that we have a nurse practitioner overseeing. And then there's physician oversight, and part of that team, of our palliative care team, Trish can, kind of elaborate on that.
Yeah, the palliative care team actually, it's a lot different than what you would typically see. I feel in a palliative care team, it's overseen by our doctor or doctors that are in the areas that we service. And then we have the nurse practitioner who is managing the care for the patient. The nurse practitioner works directly with the patient's primary care provider. So we're always in communication and working side by side with them on that patient's needs for the chronic illness that they may have. We also have the social work component, so the psychosocial needs. Nurse practitioner may do the assessment, do the follow-up visits, and see that that patient and or their family may need some support that the social work or the licensed clinical social worker, in whatever case it may be, can assist with. On top of those 3 members of our team, we also have the RNs available. So in palliative care, typically, what you've seen maybe is a monthly visit from a provider, or maybe even one visit every couple months, depending. We enhance that. We're looking at seeing our patients, as much as possible, whatever that medical need may be. But we can incorporate the RN to come in and see the patient as well. And what happens is, say a patient who typically is having some sort of change of condition, they would result in a 911 phone call and could be an unnecessary ED visit. That could lead to a readmission to the hospital. What we provide is call us. We can send a nurse out right away, do a quick assessment with the patient, talk to the family, what's going on, and then that nurse will communicate directly with the nurse practitioner that's available. It may trigger a telehealth visit, so the nurse practitioner is not immediately available in that area to do the in-person visit. that nurse will be, because we have nurses stationed in all the areas that we service. And then she or he may call the nurse practitioner into a telehealth visit that can result in, not having that emergency room visit.
Is there a certain criteria set that a patient needs to meet in order to be enrolled in your chronic condition management program?
They do. So there has to be 2 chronic care illnesses, and Dr., could you elaborate a little bit more on that?
Right, so they have to have at least two serious illnesses, which most of our patients obviously do, so they're gonna have the COPD and the hypertension. Many of these are long-standing conditions they've had that they know will progress. And as you do in your case management world, and in many of the case management worlds, we oversee these patients with the frequency that they need and with the resources that they need. We also are very progressive at this company, and we have tools that we use that really help with our outreach.
Right. So on top of the chronic care management, we also can do the remote patient monitoring. So we work with an organization that provides the patient with digital devices such as the pulse ox, the blood pressure cuff, the weight scale. So we are able to monitor all of that data on a daily basis, but it also allows the patient to monitor their own health on a daily basis as well without having to go into the clinic or the ED or
Active engagement.
Right.
Yeah.
And what we have seen with utilizing these devices is with us being able to see, there's a sudden weight gain or weight loss or something that comes back that triggers us to send the nurse or the nurse practitioner, we're able to connect with that patient right away. And again, it triggers the telehealth visit.
Wonderful. Let's see. So we talked a little bit about keeping readmissions down. So how successful have y'all been in keeping the readmissions down?
Actually, I have some data here I can share
Yeah,
with you.
I love data.
I was just thinking about
So,
that.
when we are informed of a discharge, we contact the patient within 24 hours of being informed. Check on them, how are things going? When we are informed, 85% of discharges from patients and families or other agencies, we are able to conduct that transitional care management piece, which Dr. Kapur was speaking of, for 98% of those patients. 80% of which are seen by provider within 1 to 7 days from that discharge, and then remaining are seen 8 to 14. So by us implementing that transitional care piece into our service line, the rehospitalizations have decreased tremendously as
The
well.
gold standard for that first follow-up visit after hospitalization is within 7 days, and you guys are hitting the mark.
Yes. So 98% of the patients that are not readmitted to the hospital they were not within the 30-day period. So in 2020, Transitions Home Medical Group was able to save $22 million on total cost savings for rehospitalization.
That's impressive.
And we're just gonna continue to grow and increase those numbers in 2021.
To John's
And-
point, skin in the game, right?
Yeah.
Yeah.
And just improving the type of analytics that we're using, and our company tries to stay on the cusp of what is the best resources and to kind of give the patients the best care. So
Well, readmissions is a huge issue with the hospitals because of, penalties and all these other wonderful financial things. But at the end of the day, it really does come down to patient-centered care. It really comes down to the fact that nobody really wants to be in the hospital. And if we're not equipping our patients well enough that they're at home and they're confident enough to take care of themselves, they're gonna end up back in the hospital. And therefore, the definition of readmission from CMS is a failure of the discharge plan. And as a nurse, personally, I take that really personal because discharge planning has always been the bailiwick of nursing. And you're telling me that we failed? Well, no, we're gonna throw down on that. We're gonna make sure that this doesn't happen anymore. So, absolutely.
Yeah.
Congratulations on those numbers
Thank you.
and those outcomes.
thank you.
Recently, we've been recognized, with some of the positive outcomes that we've had, that it's really led us to new partnerships. There's different oncology groups in the area, hospitals in certain areas that we service that have recognized the quality of care we're providing, and they want to work with us, so it's really helped.
Our growth has definitely has happened because of that, excellent care and word of mouth, and so we want to continue to provide that excellent care.
Wonderful. Excellent.
Thank you very much for joining us.
Thank you.